Hello, everyone. My name is Danielle Rahajasan, and on behalf of the National Center for Medical Legal Partnerships and our panelists, I wanted to thank you for taking time out of your very busy schedules to attend this session today. We are very excited to welcome you to the second of a four-part series that unpacks the learnings from the toolkit we developed that provides the health center community with information and resources to start, strengthen, and sustain a medical legal partnership. The second session will focus mainly on best practices in screening and data collection for MLPs serving immigrant populations. Next slide, please. We do want to acknowledge that this project is supported in full by the Health Resources and Services Administration, or HRSA, and that the contents are those of the authors and don't necessarily represent the official views of HRSA, HHS, or the US government. Next slide. In just a moment, I will turn this presentation over to Bethany Hamilton, who is our co-director here at MLP. But before that, I have a few small housekeeping things I would like to run through with everyone. Everyone did join in on mute. However, if you will be able to unmute yourselves to pose any questions, and we are using Zoom for the event today. So if you do have questions, please type and send those in the Q&A pane so that panelists can see them and can interact with you. Today's audio recording and slides will be made available next week on the resources page of the National Center for Medical Legal Partnership, and we will be sharing that link with you shortly in the chat as well. And if you have any questions, please don't hesitate to email ncmlp@gw.edu. So today we have an amazing panel. We are joined by Emily Arnold, who is an associate professor in the Department of Medicine at the University of California, San Francisco, by Omar Martinez, associate professor in the School of Social Work at Temple University, and is also the director at the university's Implementation Science Research Lab. We are also joined by Rodrigo Stein, who is the Director of Health Equity and Strategic Community Partnerships at Clínica del Pueblo. And finally, our own Bethany Hamilton, who is the co-director at the National Center for Medical Legal Partnerships. On the next slide, you will see the, I think it's a slide before that. Or after, sorry, where you can see the learning objectives. Sorry, yes, where we aim to provide an overview of the structure of MLPs in immigrant-serving organizations. We will describe strategies to reach and engage immigrant populations, also describe best practices for screening for health, harming, legal needs among those populations, and document effective strategies for engaging immigrants in the legal and social services continuum of care. And finally, we will identify policy recommendations to promote legal advocacy in immigrant-serving organizations. I know we're all very excited to hear from our guest speakers and panelists, so without further ado, I will pass it on to Bethany.
Thanks so much, Danielle. So let's go to the next slide. If you joined us back in January, this was a slide that I snuck in there and almost tripped up Danielle Rochester. If you joined us back in January earlier this year, you heard us bring on a health center-based MLP model that really covered laying the foundation and the basics. So what I'm going to cover today is just a much more abbreviated overview to help set, do a little bit of level setting to ensure that what Omar, Emily, and Rodrigo are going to explain about those best practices in screening and documentation for immigrant populations being served through your MLP approach makes sense, right? So I would encourage everyone to go back to the National Center website and ensure that you take a look at what Ann Mangiamelli and Brad Meyer presented back in January. Let's go to the next slide. So we know that there's a justice gap in America, right? And low-income Americans just don't get the civil legal services needs met around the country. That's not because there isn't high quality civil legal services. That's not because there aren't legal services spread throughout the country, but that is because we don't have enough. Also, we know that individuals around the country just don't often know. As a lawyer, I may not always know when I have a legal need that has to be addressed, but we know when something hurts. We often know when we have a health problem, but we aren't often walking into those places for legal care. So what is it that health centers can do, since we're serving the same populations in the health in the health center world, as civil legal services providers often do, what can we do to collaborate to make sure that folks who are walking into the healthcare providers' offices every day, into those exam rooms, especially for health centers serving some of the very same populations that LSC granted civil legal services organizations serve, get their legal needs screened for and met in a safe and meaningful and transformative way. We can collaborate through medical legal partnership. Medical legal partnership is defined as that intervention where civil legal aid services and healthcare professionals can collaborate to help patients resolve those social, economic, and environmental factors, those social drivers of health that contribute to health disparities and may have a remedy in civil law. I want to just put a footnote here to say kudos to those MLPs that are really pushing, the envelope on the traditional definition of the model, where we're addressing civil legal services and provide that civil legal services primary healthcare approach. And they're working now with the public defender's offices and really extending into a broader definition of MLP. We see you, we recognize you. We hope to highlight your work as well very soon. So what is it that MLPs are getting done? Let's go to the next slide. Just want to do a quick highlight. Many of you continue to see us coming back to this pizza pie slice, showing and demonstrating the spectrum of legal services or services in general, or activities that are carried out by MLP. So first and foremost, you're really using the MLP approach to embed legal services providers, the legal teams, the lawyers as members of the healthcare teams, to ultimately get to creating those healthier patients, strengthening the health center workforce, and improving health equity. But I want to note that it's not just legal assistance that MLPs do, right? This is more than going from the screenings to referrals and not knowing what happens. This is an approach that also helps to train your healthcare partners at the health center, building the knowledge they need to spot those social needs that may have civil legal remedies, effectuating the clinical level changes, and then finally some of the more bigger picture, broader impacts through the policy level changes. That's what MLPs do. That's how they get to creating improved population health, improved health equity, and strengthening the health center workforce. Around the country, the many flowers are blooming, but the flowers have petals, stems, roots, right? And need to be watered. And so what are those core components, using this analogy, what are those core components of the medical legal partnership? If you're continuing to reference our toolkit, you'll see this graphic come up often over and over again. These are the 8 core components of a medical legal partnership. You've got your lawyer in residence, formal MOUs, those agreements between the different partners to carry out this work. You've identified, as our panelists, our subject matter experts will explain today, a population with specific needs that can be addressed. You're screening for those specific social needs with legal underpinnings. You have dedicated resources that are designated for the MLP. You're doing information sharing. You're conducting the trainings for everyone across teams on the social drivers of health, and you're staffing it. You're doing the legal staffing, right? It's not just farming things out through referrals. You're actually staffing this with legal partners. All right, so again, we did meet in January to provide, let's go to the next slide and leave that up for a second here. We did provide in January an overview that did dive deeper into laying the foundation for building medical legal partnerships and how to fund it. I would encourage everyone to take a look at that January webinar and our Health Center MLP Toolkit. What today's speakers are going to go over is the next step, right? How do we look at your best practices in screening and documenting the legal needs of specific populations? Today, we're looking at immigrant populations. I'm going to turn it over to Omar Martinez to begin his presentation.
Excellent. Thank you so much, Bethany, and National Center for MLPs Families for inviting me to be part of this important discussion. Here's the title of my presentation today: Advancing the Science of MLPs Serving Diverse Immigrant Populations. Here's the outlines for today's talk. First, I'm going to highlight a little bit more about making the case of why the need of MLPs in immigrant-serving organizations, followed by kind of an overview of what are MLPs, medical legal partnerships, Then I'm going to highlight a few initiatives, MLPs initiatives serving immigrant populations, and wrap it up with future direction. So the why, right? Why do we need MLPs? Why we need the uptake of this framework and intervention? And our work and the work of others have highlighted the structural drivers of diseases or condition. And this particular line of work is related to HIV, right? The structural drivers of the HIV epidemic among sexual and gender minorities. And as a qualitative researcher, I always bring in those voices, and here are some of those voices. Many people won't go and seek out services because they're afraid it will affect their immigration status. For fear of being found out as undocumented immigrants, they don't go and seek help. As trans individuals, we're constantly challenged by discrimination, stigma, violence, homelessness, and lack of comprehensive trans care. Support is needed to navigate through legal and medical systems like name change and access to hormone and affirming surgery. Another participant further expanded the role of the stigma among healthcare providers. When I changed my name, a nurse insisted on calling me he. When that made me uncomfortable, I consider myself a woman. So taking a step back, right, and really reflecting of these qualitative voices from participants, it highlights that the issue is not putting on a condom, right? The issue is not behavioral at the individual level, right? These are challenges, these are structural systems that are preventing access to comprehensive service, and really highlights the need for MLPs and structural interventions like legal aid. We saw the same with COVID, right? Those initial numbers on cases and death, and how Black and brown bodies shoulder new cases and death, and how Native Americans and Indigenous peoples are disproportionately impacted by the COVID-19 pandemics. And I just want to highlight here the work of some of my colleagues, Carlos Rodriguez Diaz, Tony Apotiat, and others that really documented this. And here's the snapshot of the findings, right? Underlying health conditions did not explain disparities in COVID-19 cases and death among Latinos, Black, and Indigenous people. In these studies, social and structural conditions determine cases and death, including racism and its manifestation, systematic policies related to genocide and racism, healthcare access, housing, unemployment, occupation, and language barriers. So what are MLPs? And I think Bethany did a great job highlighting and providing an overview. And MLPs offer a structural integrated intervention that could facilitate improvements in medical and psychosocial outcomes among systematically and structurally excluded population. Through legal aid, MLPs can ensure that patients are able to access comprehensive service in a culturally sensitive environment. I just want to highlight here, what is the added value of the attorney in the healthcare team? And here's a snapshot of that added value. Legal partners can address health harming legal needs, can prevent issues from becoming legal needs, provide guidance to that clinical staff during the course of that patient cares, and prevent educational know your rights workshops for patients and community members. A little side note, and I just want to stress, because we usually focus on patient-facing legal support, and I know that Samantha Morton at the Medical Legal Partnership of Boston has been really laying the groundwork for thinking also about that team-facing legal support and the added value of the attorney, not only for patients, but also for the healthcare team, and the important distinction between these two levels of support, right? Patient-facing legal support and team-facing legal support. So I'm a big fan of Samantha Morton and her push for us to be thinking more about that team-facing legal support, and that how can improve the capacity of these health centers. Our research on MLPs also document the importance of identifying the level of severity of health harming legal needs, initiating action to resolve legal issues early on in the clinical process, and coordinating with medical and health social services to support patients throughout the resolution process. We also have found out core components of effective medical legal partnerships, including those housed in immigrant service organization. support of leadership, right? That administration that is a champion and really believe in medical legal partnership. Provider-patient trust, right? That cultural humility that is important within that organization. The physical presence of the attorney at the healthcare center, right? That was key, that has been key. And we have documented that in our quantitative and qualitative work, right? The importance of having that attorney on site right after that screening of health harming legal needs. And of course, we're all aware of having reliable funding streams. I also wanted to highlight here the work of Dr. Jamanis. I'm glad that she's also in the audience here, and her contribution and trying to build the evidence of medical legal partnerships in support of trans Latinas and trans women of color. So highly recommend checking out this little paper that she published a few years ago. We also have studies that show that MLP services reduce healthcare spending on high needs and high patient costs and high cost for patients. MLPs have been shown to save patient healthcare costs and recover cash benefits. And here's some of that scholarship, including the white paper that was published 2 years ago at the National Center for Medical Legal Partnerships. So Omar, tell me more about initiatives and what is happening. We just embarked last year on this great project looking at medical legal partnerships to improve HIV care continuum outcomes of people living with HIV, including immigrant populations living with HIV. In fact, this was the first NIH-funded study on medical legal partnerships, so we're very, very lucky. Here are some of the materials that we have built. These are thinking as an implementation science expert and how this will work, thinking about implementation factors that may enable the success and the uptake of medical legal partnerships, looking at organizational characteristics, looking at the existing portfolio of interventions within the healthcare centers, priority populations, and processes for data sharing and so forth. One of the key things that we found in our formative work is that within these MLPs, serving people living with HIV, there's 3 continuums of care, right? When we look at the care for HIV people, we always think about HIV care continuum. But what we found is that within these MLPs, there's also the legal continuum of care, right? Effective processes for screening and addressing health harming legal needs, as well as the social service continuum of care. Here's more about our package and what we're testing, following the typical logic model, thinking about inputs, intervention activities, as well as outcomes. We're doing training for providers. We're doing case management training as well. We're embedding legal expertise within regularized case management team meetings. And we're also developing practice and tools for communication and data sharing among these MLP experts. As part of this study, as part of the formative work, we also develop a screening for health harming legal needs on the right, based on existing models and existing screening practices. We consulted with the National Center for MLP Screening. A big shout out to Legal Aid Project of South Florida that also contributed and was part of the processes for developing ours. And here's the snapshot of their own screening instrument. And once again, on the right side is the end product for our screening instrument, looking at income, employment, housing and utilities, immigration experience, and personal and family stability. Here's a snapshot of our training for providers embedded in these MLPs. Once again, an introduction of the HIV care continuum, health harming legal needs, how to screen for health harming legal needs for people living with HIV, integration of legal services and medical services, and MLPs in action. And I'm happy to share this training that we developed with the audience later on. Other practices, and I'm honored to have joined Dr. Eva Moya and Silvia Chavez Baray. They're thinking outside the box, and they have actually employed photo voice methodology to identify health harming legal needs, as well as addressing health harming legal needs. We just got a paper accepted at Frontiers, pending minor revisions, on how we use photo voice methodology once again to identify health harming legal needs and addressing health harming legal needs among trans Latinas in El Paso and Juarez, Mexico. I just want to play a brief piece of this important video.
Una frontera que divide lo que fue y lo que será. La felicidad que te augura y lo que dejas atrás. ¿Cuánto puede cambiar la vida de una persona que ha sufrido por tanto tiempo? Y cuando cruzo esta frontera y me veo al espejo, no veo lo que fue, veo la esperanza de un futuro mejor.
Unas vías del tren, las vías y yo, que hay que tratar de sobrevivir por no contar con el apoyo del gobierno. Y tenemos que buscar la manera de mantenernos, ser más unidas.
Excellent. So once again, I just wanted to provide a little snapshot of how this innovative tool, photo voice methodology, using photo voice methodology for screening and addressing health harming legal needs. Other initiative happening across the country, big fan of Whole Person Care Los Angeles. They developed an excellent MLPs in Los Angeles, Texas, Los Angeles, California. Here's a snapshot of their approach and citations for their work. Future direction as it relates to MLPs, we need to enhance the impact of MLP implementation strategies. We need to be conducting more effectiveness trials of these models and care models. We need to harness implementation science to promote health equity and increase the economic evaluation of these MLPs implementation strategies. We need to be talking about upstream factors, right? These social and structural determinants of health. Here is a quote from Dr. Bullock, one of my favorite, one of my colleagues. We need to be talking about intersection structures and not identities, recognizing that intersection structures shape health outcomes. We need to expand robust MLP community research collaborations, right? Defined and guided by recognition that community development is an important focus of research, commitment to building upon the strength and resources of individuals and communities, promoting a process that actively addresses social inequities and disseminating those study findings. I just wanted to close with, the added value of community health workers and promoters in this MLP journey. We can't be doing this work without the presence and support of promoters and community health workers. They build trust, they provide social support, they identify patients' health harming legal needs and risk, they lead patients to social and community resources and engage in outreach, advocacy, and community initiatives. A big thank to our study participants, community partners, and members of our research team. And with that, I pass it on to Dr. Arnold for her presentation. Thank you so much.
Thank you, Omar. You're always a tough act to follow. All right. So good afternoon, everyone. Thank you so much for taking time to join us. My name is Emily Arnold. I'm a professor at the University of California, San Francisco, where I lead the Northern California HIV/AIDS Policy Research Center. I'm going to be speaking to you today about a case study that we conducted a few years ago, trying to understand the best practices around engaging people living with HIV from immigrant communities in their HIV care. And the role of medical legal partnerships within that context. So I think it's really important to orient all of you to the somewhat unique state and local policy context we have here in California. California has an estimated 2.4 million undocumented residents, and particularly since the election of Donald Trump has put progressive policies in place to protect and care for our population. That includes the California Values Act, which was passed in October 2017, which prohibits the use of state and local resources to assist with federal deportation efforts. The declaration of certain sanctuary cities, which include San Francisco, Oakland, and Los Angeles, all of which I should note are HIV epicenters. And the expansion of comprehensive Medicaid forms of public insurance plans to all low-income residents up to age 26, regardless of their immigration status. That program is actually due to be expanded as of May 1st for all residents ages 50 and over. And Governor Newsom actually has included funding in his January budget proposal to expand Medi-Cal to those between the ages of 26 and 49 starting in 2024. So there's a serious dedication on the state and local part of policymakers to look after our entire population, regardless of their immigration status. So within this dynamic political landscape, we really sought to understand the best practices for maintaining access to HIV care and prevention for immigrants living with HIV, particularly in an era where our state and local ordinances were in direct opposition to federal level policy efforts. Very briefly, we conducted in-depth interviews with 20 key informants in 3 different counties around California: San Francisco, Alameda, and Fresno. And our data collection actually overlapped with the Trump administration era and took place from May of 2018 through January of 2019. Our interviews lasted between 60 and 90 minutes, were audio recorded and transcribed. We inductively and deductively established our themes and then developed a code book around those and applied our codes across our entire data set. We were interested in broad best practices that clinics were putting together in order to preserve access to care for those living with HIV. So our topics were actually pretty broad. These included clinic services, populations our clinics were serving, and funding streams that supported those services. We also sought to document best practices around maintaining access to care, which included linguistic and cultural competency, the establishment or development or sustainability of medical legal partnerships, case management and the role of case managers in providing access to wraparound services. And by wraparound services, I'm talking about food security, employment assistance, housing assistance, and transportation needs, and maintaining health insurance coverage for people living with HIV. Today, I'm going to be really focusing on our data related to medical legal partnerships and the degree to which those were in place or in development during our period of data collection. For this talk, I'm going to really focus in on 3 main areas of our findings. One is that we really saw high demand for legal services for immigrants living with HIV. Secondly, we documented a number of best practices and the really important role of relationships, not just between medical providers and legal agencies or attorneys, but also especially between case managers and patients. And often case managers served as a bridge for providing access to legal counsel for our patients living with HIV. I also am going to share some thoughts from our participants around the additional resources and guidance that they felt were needed to be able to support their patients with legal needs. As I mentioned, we recruited and spoke to 20 individuals. About a third of those were medical providers, a third were case managers, social workers, or peer navigators, and a third were either legal or policy experts or clinic administrators. So one of the first and most frequent responses we heard about when we asked participants to describe the changes that they had seen with their patients since the Trump administration had come into office was the sense of urgency around establishing citizenship, as well as understanding benefits and the implications of accessing public benefits in terms of the determination for public charge. In addition to this, we also saw a great deal of heightened anxiety within the community, but varying reports of impact on the continuity of HIV care. For patients who had been established at HIV care clinics and already had trust in their providers and the teams that they had been working with often for many years, those patients continue to show up for their medical appointments. However, for those who were newly diagnosed, our key informants reported that a number of individuals have been lost to follow-up due to concerns around immigration. Like Omar, I'm a qualitative researcher, so I can't do any kind of a presentation without forefronting the voices of our key informants. So I'll just very briefly give you a couple of highlights from our study. There's this urgency of, oh my God, I should get my citizenship. People are scared with everything they hear in the news every day. It's an attack on someone's rights. It's literally some sort of attack on someone's personal space and emotional and social well-being. Even if it's not directly happening to them, it does seep into people's psyche. And I think there becomes this community level of anxiety and a heightened sense of urgency. We heard this from providers, case managers, and clinic administrators. And we also heard that sense of urgency being reflected in clinical staff themselves and feeling like they needed to have particular tools in place and procedures to deal with this change in the political landscape around immigration and immigration enforcement in particular. So as I mentioned, there was definitely a lot of concern around the implications of accessing public services on public charge. Given the fear around the changes in the public charge rule and the misunderstanding from our populations, we've seen a lot of folks just kind of pulling back, asking to be disenrolled from programs just simply because of not understanding what's going on. And if this causes me to be deported, I'd rather not use it. And that fear is what we think is the actual driver. And that's what we're going to see the impact coming from: fear, misinformation, and confusion. So as I mentioned before, there was a real need on the part of our clinical staff to provide accurate, up-to-date legal information. These are just a few of the best practices and recommendations that were shared with us in our interviews. Certainly, our participants emphasized the importance of developing and maintaining medical legal partnerships. And I will say that actually, for the most part, we did not interact with clinics that had legal representation or counsel on site. Many of these legal and medical legal partnerships took place through referrals. So this is a slightly different model than the one that Omar has just described. But there was a real need for harnessing legal expertise, particularly around clinic trainings and protocols. So we saw the need of clinics inviting legal experts to present to the clinic staff, for example, on public charge, and also to help clinics establish procedures, for example, dictating how interactions with immigration authorities might take place within clinic sites, establishing the difference between public spaces, for example, in waiting rooms, and private spaces, for example, in exam rooms. Relationships, as I mentioned, were absolutely key to this endeavor. The relationships between medical providers and attorneys or legal staff, but also, as I mentioned, that role of a case manager and support services, being able to provide warm handoffs was really, really vital and important. And finally, one of the key best practices that we saw emerging in our work was the need to really institutionalize client-centered, culturally sensitive care. And that included language concordance, a sensitivity to meeting people where they were at, and also providing wraparound services. We are fortunate in some ways to have access to Ryan White funding for people living with HIV, which includes access and support for legal services and referrals to those services for people living with HIV. So again, just a couple of quotes. There's a special synergy when you get to know the providers. You can call the medical social worker or call the doctor because my client's not showing up to their legal appointments. It made it so much easier to have that trusting relationship to be able to get the kinds of documentation we needed to support our cases and vice versa. The relationship, and again, that central importance on the relationship was mutually beneficial. We also saw, again, that importance around institutionalizing client-centered, culturally sensitive care. Some of our case managers would walk the person to the lawyer's office. The experience changes when the work is client-centered and non-judgmental. Having someone who perhaps has been through that process before someone who looks like them, someone who speaks their language is really, really helpful. It develops that trust. So once again, that theme around establishing and maintaining trust with patients and clients was essential. Having people who had had experiences of immigration themselves, providing those services, once again, allowed for that referral to take place successfully. And our final theme is probably not surprising to most of us, which was that our informants really felt that more resources were needed. And those really took the form of two different things. One was training for clinic providers and support staff. Our medical providers in particular wanted to have training on helping with assisting asylum seekers, as well as assessing immigration needs. So really wanting to have effective screening protocols in place for case managers to be able to assess legal needs as part of a more holistic needs assessment that would take place as intake, as well as just ongoing routine care. Our legal experts really detected a wide variety of practices around assessing legal needs and felt that there needed to be much more comprehensive guidance provided in the ways that this could be done in the clinical setting. And then, of course, although we had access to Ryan White funding, there was a call for more established funding streams to formalize as well as to support and sustain ongoing medical legal partnerships. When I first started as a physician, I really didn't know what to write in the asylum letter for the lawyer. There are no guidelines. And actually what helped me was one of the providers shared their letter that she'd written for a patient. So again, you just see this like very ad hoc, just a description of how providers who really want to help their patients gain asylum on the basis of their sexual or minority identity and an HIV status really had no clue how to go about this. And then we heard from a legal and policy expert about what we're proposing is that there's a much more consistent manner of screening throughout the department, throughout all of the clinics, because you wouldn't want anyone to fall through the cracks if in fact there may be an opportunity for them to legalize their status. So to build trust, we really see that it's necessary to institute patient-centered care models of delivery of healthcare, as well as wraparound services, which really would include legal services as well. And that really necessitates diversifying and retaining, especially in a post-COVID era, the healthcare workforce. We need to also think about developing tools to assess legal needs as part of more comprehensive needs assessments that take place as part of routine care. We're going to need to try to identify local, state, and federal level resources that can be used to provide access to counsel for a variety of legal needs. And those might include anything from immigration needs to employment discrimination needs to housing needs to any number of other needs. So there's not just our respondents reported that there really were a wide variety of services that could be met through the medical legal partnerships. And then finally, I think it's very powerful for us to think about elevating patient experiences and voices to advocate for this change at the policy level and to create additional funding streams and resources that will make legal aid more available, particularly around immigration needs. Thank you so much, and I really look forward to hearing thoughts from my fellow panelists. I'm going to stop sharing.
Thank you so much. My name is Rodrigo Stein. I'm Director of Health Equity at La Clínica del Pueblo. Thank you once again for giving me this opportunity, and I hope to bring the perspective from the health center side of how to promote culturally responsive medical legal partnerships at an FQHC. So next slide, please. Next slide. I'd like to begin, as always, to contextualize the history of our organization and also provide some context when we speak about immigration. Who are we referring to? What is the process? Now, stay on the previous slide. So it's important to remember that foreign-born migrants maintain strong, effective social, cultural, economic, and political ties with their places of origin, the culture of our homelands, our lived experience in our countries of origin, and the ways these factors interact with our lives all have an impact on our health. Our migration story, why and how we came to the US, and the length of time we have lived here has a direct relation to our health outcomes, health-seeking behaviors, and ability to navigate the US healthcare system. However, most importantly, what I would like to highlight from this short introduction is when we speak about immigrants, refugees, or asylum seekers, there are no border crisis, immigration crisis in the United States or anywhere else. What we do have are actual crises that drive mass migration, such as capitalism, war, and the climate emergency, and imagined crises at the political borders, which are used to justify further border securitization, violence, and exclusion. Next slide. So who are we talking to in the case of La Clínica? Who is migrating to the DC region where we're locating? Countries of origin for immigrants in the DC region particularly relate to 3 countries: El Salvador, Guatemala, and Honduras. From 1980 to 2015, the size of the Central American population grew nearly a tenfold in the US, now totaling about 3.3 million, which is about 8% of all immigrants in the US, with the DC metropolitan area being the 3rd largest in the country housing Central American refugees. So why are they arriving? Next slide. And I know this slide has a bunch of information, and I tried to condense as much as I could. And the y-axis tracks the number of migrants in the United States, while the x-axis tracks the years from 1960 to 2016 for critical social and natural disasters in El Salvador. As you can see, there's a close relationship between multi-generational exposure to violence and traumatic events, such as war, earthquakes, poverty, and violence, and the rates of migration. The blue blocks in this slide show major inflection points in the history point of La Clínica del Pueblo's history, which closely resemble major events in El Salvador that have shaped the type of services that we provide. Moreover, this graph also indicates how complicit United States foreign policy interests have been in shaping migration flows. For example, due to the politics of the Cold War, Salvadorans and Guatemalans refugees were not accorded refugee status, since the US was supporting military governments in those countries against the opposition. So that limited the type of services and type of health coverage they can get. Despite between 1979 and 1992, almost 500,000 Salvadorans arriving to the US. This impacted, as I said before, the type of health services of the population was able to receive. Additionally, the violence that remains so endemic in El Salvador today was accelerated due to deportations and tough on crime bills passed in the 90s, which led to the creation of some gangs in El Salvador and in Los Angeles, which then were deported back to El Salvador. So my hope with this slide is to track sort of the history of the rate of migration and how closely it's tied to US foreign and domestic policy, as well as natural and social disasters. Next slide, please. So about our organization. La Clínica is a federally qualified health center and a patient-centered medical home, as well as a community-based organization. In 1983, Salvadoran immigrants in the United States, health advocates, founded La Clínica del Pueblo in a response to the emergent health needs of displaced migrants due to civil war and state-sponsored violence. For many of these immigrants, accessing healthcare services in the United States was nearly impossible due to the cultural, linguistic, and economic barriers they faced. Additionally, since these conflicts happened during the Cold War, as I said before, asylum and refugee status were not afforded to them as their governments were under the United States sphere of influence. Next slide. So who are the population that we see currently? We see about almost 5,000 patients a year, 92% Latinx, 80% from Central America, 35% are uninsured, and 83% feel comfortable of limited English proficient. 84% have an income below of 200% of the federal of the poverty line, and we see about 20,000 additional community members through our community health action team. Next slide. what are the barriers that we commonly see with the population? So we know they're overrepresented among the undocumented and those holding temporary protected status. They lack eligibility for many safety nets, including Medicaid, because they're less likely to meet the 5-year bar and the ACA provisions for undocumented, and rely on local health coverage via what we call the DC Alliance, which is a local insurance program in Washington, DC. A lot of them are from mixed immigration status families with different access to different benefits, safety and security, and are overrepresented in the service industry, trades with few workplace benefits, and were the essential workers that kept our cities running during the pandemic. Also, because of the trend of the history of migration to the region and our organization, we're currently seeing more and more of an aging population residing in multi-generation housing. Next slide, please. So this is just a overview of the organization and the types of services that we provide. We have primary medical care, mental health, and substance use. And we have our public health branch, next slide, which is what I'm going to talk about more, which is our community health action and our health equity team. So our community health action team is really focused on expanding access, providing health education, support groups, and embedding promotores or community health workers into our service delivery, as well as creating safe spaces for sensitive populations such as LGBTQ migrants, as well as survivors of domestic violence. Our health equity program specifically focuses on mapping barriers or identifying social needs that affect health outcomes, addressing language barriers through the coordination of medical interpretation, advocacy, and developing cross-sector partnerships. Next slide. So what is our approach to establishing medical legal partnerships? As I said, it's always important for us to begin to recruit from the community, recruit people who reflect the people who receive services at their doors, but most importantly, understand the roots of migration, understand the structural conditions that as we've been speaking about that have driven waves of migrants that come into our door. The second step that we apply to identify medical legal partnerships is identify partners who understand that story, understand that these are not behavioral deficiencies, but are rather the structural and social determinants that push people into these needs. The third component that we do is we provide structured ways to collect social determinants of health data through our electronic health records, but also embedding in the safe spaces, embedding promotores and health educators who have that affinity and trust with the community, so they can collect additional level of information that can be then transmitted to a legal partner. We shape the partnership and share the data that we're finding, and then we hopefully, with that information, we can provide improved health outcomes for populations and ultimately impact policy. Next slide. So who's collecting this social determinants of health data? So as I said before, 80% of our staff at La Clínica are Latino, 70% of our leadership is Latinx, and it's collected through all layers of the organization, from the intake team, the care coordinators, providers, medical interpreters, health educators, and promotores. Next slide. So what tools are we using to collect that data? We primarily use, when we speak of embedding it in the electronic medical record, the tool Prepare, which is a protocol for responding and assessing patients' assets, risks, and experiences. And as it is already embedded in our EHR, this complements other ways that we are collecting social determinants of health, such as community assessments that we do in community events with promotores, our safe spaces with Empoderate and Entre Amigas, which cater to specific and sensitive populations that allow for that connection with the community, trust, and are able to collect those social needs, which then can transfer into legal needs. Next slide, please. In terms of the major things that we're seeing, and Prepare backs this up, as well as our way to have individual meetings with the different teams, care coordinators, health educators. We see food insecurity, economic instability, housing and transportation consistently come up, with is also an indication of the structural deficiency and the social determinants of health that add on to immigration, primarily an economic inequality and low wage work that the majority of our population work at. So how to identify these partners that understand all these barriers? Primarily, we have a very active presence in diverse coalitions. Promotores, we keep coming back to promotores. They are in the community. They are the ones who are going through some of these, and they are an excellent source of information to report back of resources that we might not know, but also in diverse, as I said before, coalitions and areas to enhance primary care, such as our DC Positive Accountable Community for Transformation, which is trying to unite within the district, both community service organizations and health centers to really put forward how the social determinants of health need to be collected, systematized, and affect policy. Next slide. So what are some of the examples of the medical legal partnerships that we have at La Clínica? And we focus specifically on specific patient populations and all social needs. As I said, it's the social determinants tied immigration plus economic inequality, plus then the different levels of exclusion based on identity, such as our LGBTQ program, Empoderate, our gender and health program, Entre Amigas, and patients with chronic conditions. We try to cater these legal services to those specific needs. Because we're also a small organization, a lot of these partnerships depend on certain grants, which allows us to have a buffet of medical legal partners and not necessarily focus on only one. Next slide. How can we be more effective when we are trying to structure those partnership meetings? So we use what we call the Partnership Assessment Tool, or PATH tool, which is designed for community-based organizations, healthcare organizations in existing partnerships, and assess how organizations may work more effectively to maximize partnerships via benchmarks. So these benchmarks are rated on a scale from 1 to 5, and they capture everything from internal and external relationships, data and outcomes, and funding. So these are the categories that allow us to really structure how to be more effective when we work with these legal organizations. Next slide, please. In terms of how do we increase communications, we try to bring as much training from the medical, from the legal organization into the medical workflows. So we host trainings. For example, this is one that Legal Aid provided on housing law issue areas to all our care teams. And one thing that we're finding that is incredibly helpful for the organization, next slide, please, is to centralize our partnership data for all the care teams to see. So even though they're built on specific patient and specific patient needs and the legal partner, the more we can document and share that information across the organization, we can definitely strengthen if patients need external referrals, how this communication is identified within the organization. So we've created what we call a health equity hub, where we have all this information for legal partners. One thing that we've also find has been quite effectively is designing one person to be that main connection with the legal organization. And in terms of the workflow, designing that referral process has been key. Next slide. But as I presented in my first slide, our approach is always to try to impact policy as well, not necessarily stay at the individual social and legal need, but actually how do we promote and impact policy. So we've been active in, as I said before, a number of coalitions, including the Immigrant Justice Legal Services in the District of Columbia, which has fought and actually was awarded almost $5 million for selective grants for complementary non-legal services, as well as increased funding for detained representation. And through our coalitions, such as the DC Alliance Coalition and our partnerships with legal aid, we've really pushed for the elimination of structural barriers to the DC Alliance, which is the main source of care for immigrants who are not eligible for Medicaid or private insurance in the district to obtain care. So a lot of it is always aiming for sustainability and impacting policy. Next slide. So what are the challenges and the best practices from the health center perspective? One of the biggest challenges has been a complete standardization across all care teams to collect, prepare data. So a lot of it is related to grant funding and the amount of staff we have available. For example, Prepare now is limited to Ryan White patients, patients who need care coordination, and other grants that cover those social needs. So it's closely related to funding. We're also well aware that if we're trying to impact policy, that change will not always happen in the immediate term. So there's it's a marathon, not a sprint. So always not to get too discouraged. In terms of best practices for medical legal partnerships that we have, always MOUs. The best partnerships that we've been able to establish, for example, with legal aid, has been that shared workflow. Who is going to be collecting the data? Who are we reporting to? That has been key. The safe spaces, as I said before, like our population is quite diverse, and not all Latino immigrants have the same needs and need that level of trust with different approaches. So I think the establishment of safe spaces allows for that additional trust and culturally and linguistically appropriate manner allows for the ease for the community to present their needs. Integration of promotores has been consistently something that has elevated our ability to refer people to legal organizations, but also the trust that communities face when dealing with organization. If someone looks like them, talks like them, and speaks like them, they are more inclined to share some of the barriers that they're going to. Plus, they know they've been through a similar scenario. Warm handoffs are key. That is definitely one of the best practices that we have. As I said before, language access and maximizing the use of these technologies, such as Zoom. People have work hourly wages, so taking that time off is also has an impact to their bottom line. So if we can work around these technologies and use them responsibly, we can see better outcomes. Having regular discussion around indicators and data sharing is key, specifically because legal and medical organizations sometimes work on different levels of privacy requests. We have HIPAA, and then I'm not a legal expert, but I know there's a legal confidentiality. So that data sharing and how it's going to be shared is key. And in terms of strengthening the information within the organization, centralize the information in a way that is visually engaging and easy to access. We, as a small health center with a lot of work on our hands, the last thing we need is another encyclopedia or something that takes a lot of time to understand, or a massive spreadsheet with 84 columns just to get a contact person. So really make that information visually engaging is key. And finally, the interagency training. So the legal organization to understand the social barriers associated with immigration and our population, but also for care coordination and for the medical team to understand when a social issue is a legal issue. And that is the interagency trainings are key to strengthen some of the medical legal partnerships. And I think that's time for me. And thank you so much for the opportunity.
Thank you, Rodrigo, Emily, Omar. Thank you, thank you, thank you. Also, thank you to the audience for sticking around with us. They're sticking around. So we're going to try to get at least one of these questions answered in that came in through the Q&A. And I promise we'll try to do our very best to follow up. Danielle, let's get one of those questions answered.
Yes, so there was one question about some restrictions on the type of legal services LSC-funded organizations can provide for undocumented populations. So if your legal partner is LSC-funded, what percentage of legal needs or referrals would you estimate that your LSC-funded entity is not able to provide? Do you actually provide immigration-related services or just non-immigrant related services for immigrant populations?
Very highly technical question focused on LLC. Omar, actually wondering if you want to take a stab at this one first.
Well, I'm a researcher. I'm in the ivory tower, but that's an excellent question. And I'm aware of these limitations with LLC funded sites. What I do know is innovative models, right? That some of these health serving, these organizations are doing referral to other key partners that are not restricted based on LSC funding, right? So there's other mechanisms to still provide legal aid to immigrant population through these mechanisms of referrals. I know that here in Philadelphia, I work with TPAC, an organization that serves immigrant population, and they have like pretty much networks of pro bono attorneys that they could refer their clients to when they cannot refer to Philadelphia Legal Assistant, because Philadelphia Legal Assistant is LSC funded, right? So is that building from that referral networks, pro bono attorneys, working with law schools, right? Those legal clinics are essential. They're not limited to LSC funding. So these are some of the mechanisms that Rodrigo highlighted, right? Having a legal partnering family. You saw that slide with like 20 partners, right? Thinking about having a mix of LSC funded partners and non-LSC funded partners. So just wanted to add that.
It's a great, thank you, Omar, for pointing it out. And I was just also noting in the chat, that to add to that, there are MLPs that have and do utilize those various partners because of those restrictions. The same thing may play out as well on the healthcare side of the equation. Just going to try to sneak it in. Do we have time for one more question? Just want to ask the panel, can we sneak in one more question before we close out? All right, Danielle, do you want to pose one more and then I'll close this out?
Can you provide examples of how clinics can screen for immigration-related legal needs or risks without explicitly asking about patients' immigration status?
I think I'll take that. I think for La Clínica, like we never ask immigration status. I think the more trust, and this is where the incorporation of health educators, promotores, and staff who understand immigration as a social determinant of health, who have been through the process, who are immigrants themselves, is key, as that way people, the issue is food security, but really it's an issue of mixed status families. It's an issue of I have TPS, I have this legal barrier towards my immigration status. Well, it is how you call it, a social need that comes in, but once you establish that level of trust, well, no, it's really my documentation status is affecting the type of service that I can lead. But I think knowing the barrier and knowing the additional burden, I want to say burden, but the additional level of complexity that immigration adds to already existing social determinants, such as housing, such as our food environment, is key. That way, if the patient comes in with a social need, which is tied to economic inequality, that trust then leads to people saying, well, no, it's really, I'm in the process of renewing my temporary protected status. I'm undocumented. All these things really are key if you have an organization that understands immigration as a social determinants of health, has staff that understands it, and also comes from that background. And I think those are the
Super helpful. Omar, did you want to add one more thing before
Yeah.
we close out? Thanks.
Once
Rodrigo.
again, full disclosure, I'm sitting in the ivory tower, but doing research with and for these communities, I have seen a strategy and across all these partners, as a result of your immigration status, have any of these services been impacted, right? So you see how they frame it, right? As a result of your immigration status, have any of these things have been impacted as a result of your immigration status? So it's not asking, are you documented or not, but as a result of your documentation status, have any of these conditions, have you been impacted by any of these conditions, housing, food insecurity, right? And so forth. I do want to, Dede, I think, pointed a question about focusing on risk. And I think that from a conceptual standpoint, I think that's the way to go. Thinking more about health harming legal risk. And by the focusing on the risk, conceptually help us think about more preventive legal aid, right? How can we prevent these legal needs from happening, but by focusing on that risk? And I think that that's why I'm a big fan of La Clínica and these others, is that they have a lot of information, know your rights workshops. So it's focusing on that preventive legal aids and empowering clients and focusing on that prevention component of the legal continuum of care. And by thinking on risk, it helps us think about the importance of advocacy and the importance of preventive legal aid. That was some point, and I just wanted to bring that on Didi's point. Emily, any thoughts on that? I know you have conceptually me moving towards that direction as well. Any thoughts on that?
No, I totally agree that we need to be integrating this in a way that is that doesn't disrupt or undermine the trust that has been so painstakingly built between medical providers, clinics, as well as legal agencies in order to bring this more to the fore. But trying to integrate this in a more holistic way, to really think in terms of preventing issues from arising and getting ahead of them, and having trusted partners that can be referred to, handed off to, vouched for, I think is really going to be an essential part of that.
Couldn't agree more. I want to encourage everyone to continue to look at the ways that your screening tools that you're currently utilizing can help you to do some of that risk identification and stratification to be able to better target your SDOH interventions, such as the MLP approach. So right people in the right place at the right time with these very limited resources that we are all utilizing, especially through the MLP approach. So with that, I want to thank everyone in the audience, as well as our panelists, who are sticking around a little bit longer with us today to get these questions and answers in. For the West Coast folks that tuned in, we did host a later webinar, especially to make sure that you all, plus our friends out in the Pacific Islands, Hawaii, Alaska as well, could join in. So for everyone who's on the East Coast, thank you for sticking around with us at this later hour. Our panelists, Emily Arnold, Omar Martinez, Rodrigo Stein, thank you for sharing your knowledge today. Folks will notice that when we post the slide deck on the National Center for Medical Legal Partnerships website, you will be able to see some additional slides with resources that we've actually already built into this slide deck, in addition to the ones that came in via the chat. So we'll ensure that everyone has access to those. For the questions that we did not get to answer live today, we'll do our very best to at least point you to resources that will help you get to the answers if we don't have them right off the bat. But that's a wrap. I want to thank you all for joining us on today's part 2 of our Health Center MLP Toolkit webinar, and continue to tune in to our newsletter for updates related to parts 3 and 4 of the webinar series. And don't forget to view the recordings when they come out. When you get the follow-up email from Zoom, please, 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 this is funded by HRSA. We do want to know through the evaluation link how well we did. And hopefully we did very well. So I want to thank our panelists again today and our audience, and say that's a wrap. Take care. Bye-bye, everyone.